strength meets clinical uncertainty. I welcome my co-chair, Professor Adami from Verona, Italy. And as I said, it's an interactive session, so we are going to have case presentations today. And afterwards, we are able to vote. So please use your EULAR apps for voting. And then we will discuss your decisions, our decisions, and also the cases with our experts. So let me introduce our experts and ladies first. Dr. Barbara Hausner from Edinburgh in Scotland. She's consultant rheumatologist with special interest in metabolic bone diseases, osteoporosis risk prediction in RA, and MTX osteopathy. Welcome, Professor Kenneth Sark. It's a great honor to have you here. Professor Sark is one of the biggest players in our field. He's chair and director of the Division of Clinical Immunology and Rheumatology at the University of Alabama at Birmingham. Welcome, Professor Sark. And last but not least, again, a very big honor, Professor Frank Budgereit. He's deputy head of the Department of Rheumatology and Clinical Immunology at the Charité in Berlin, Germany. I hand over to you, Giovanni.
Well, thank you everyone for being here today. My honor to present our discussant today, which is Professor Judith Everts-Graber from Bern in Switzerland. She's a rheumatologist and she's an expert in osteoimmunology and osteoporosis treatment. So she's going to present a few cases, very practical case scenario on daily practical in osteoporosis and in metabolic bone diseases. And she's going to have questions during the session. We're going to have you voting and the expert answering as mentioned before. So please, Judith, the floor is yours. Thank you.
Thank you very much for inviting me to this exciting session. I have nothing to disclose, and all patients whose cases I'm going to present now have provided their consent. They do that because we include them in a large registry, and if you're interested, you will find more information about this online. Now I start with the first case. It's a 56-year-old woman with a normal BMI, and she was referred to us because of a vertebral fracture. She sustained that during a hyperextension during a yoga exercise. And she had a history of an early breast cancer. She was initially treated with tamoxifen. She was still premenopausal back then. And later she received an aromatase inhibitor for a bit more than 1 year. Back then she did not have a DEXA scan or an anti-osteoporotic treatment. Her lab results were quite unremarkable, normal calcium and vitamin D. And this is her DEXA scan, and you see that she has osteoporotic values at the femoral neck, -3. The lumbar spine was -1.5. And back then she was treated with denosumab. I personally would have opted for zoledronate, but back then denosumab was very big in Switzerland. It was before the whole rebound issue. And she received denosumab for 5 years. And then her bone density increased by 6% at the lumbar spine and 7% at the total hip. However, she was still in the osteoporotic range with -2.9 at the femoral neck. She wanted to stop denosumab. She heard of the rebound issue and she told me that she wouldn't take this drug anymore. And so we decided to switch to zoledronate. And we gave her the first zoledronate infusion 6 months after the last denosumab injection. And then we measured the markers. Back at the first zoledronic infusion, her markers were still suppressed with a P1 and P in the lower normal range. But only 3 months later, they increased rapidly. They were now highly elevated and the CTX were above the premenopausal range. And that's why we gave a second zoledronate infusion 3 months after the first one. And then 3 months later, she came back to us and we measured again the bone turnover, and the markers came down a little bit, but they were still increased in the upper normal range. And now we asked us, should we give her another solidronate infusions, or are there any other options how we could manage this rebound? So now this is your turn. Please take your phones, and you can choose between these options. We could give, as mentioned before, another solidronate infusion, or we could continue to monitor the bone turnover markers, see if they decrease further, and repeat a DEXA scan to see how the bone density developed. The third option would be to restart denosumab, as denosumab is the most potent anti-resorptive agent we have and would certainly decrease the markers. Or we could consider an anabolic therapy. It's still a young woman, she had a vertebral fracture, and why not giving her an anabolic agent? So now you have 20 seconds time to vote. Thank you very much. You see here the results, and now I hand over to the experts. What do you think? Is this a good idea to give anabolics or to just wait?
Who starts?
I'm happy to start. So I think it's a very interesting case. You know, I'd like to know a little bit more about her. There's a couple things that are troubling me. One is the discordance between her bone density at her spine and her hip. And it's somewhat unusual after 2 doses of zoledronic acid to still not have suppressed the rebound from denosumab. So I'd at a minimum want to check a PTH. I imagine you've done that. I know
Yes.
it was done initially and it was normal, because that would be one of the things I'd be concerned about when you see that sort of discordance. You know, in a younger person like this who's had 2 doses of zoledronic acid, I'm very drawn by some of the newer data out of New Zealand that, you know, shows that a single dose of zoledronic acid may last 10 years. You may see effects on bone and bone mineral density for a very extended period of time. So I think I'm inclined, I know the winner was anabolic, but I'm probably inclined to go with number 2. I'm just concerned, first of all, that I don't think she's going to get much bang for the buck with an osteoanabolic after 2 doses of zoledronic acid. And so this fracture she had during yoga, are we sure it was during yoga? Could it have been a prevalent fracture? She's got low bone mass. I think she probably, in fact, has osteoporosis, but you always worry in a younger person about low peak bone mass. In the setting of the vertebral fracture and with bone density and an osteoporotic range at the hip, I think the diagnosis is pretty clear. So I think we have to take it pretty seriously. And normally she would be a candidate for an osteoanabolic, but I might have used it sooner.
Thank you very much, Professor Puttgart.
So I would be joining the 35% who have voted for option 2. Also because of the other options are not convincing to me. Number 3, restart denosumab, is not in line with the wish of the patient. So that is rather a theoretical option. Why should that be now changed? Then consider anabolic therapy, you already explained that. And really, number 1, I mean, 3 or 3rd infusion within 6 months, that could be too much of the good, right? And I could not see an additional positive effect here. So I would be voting for 2. And there is a certain rationale behind that. But let me just comment on your remark, because you were just saying, I would have started with solidronate instead of denosumab. Is that right? Mm-hmm. And I would like to join you there. Why is that? Because breast cancer is a tumor. Mm. And we all know that the N-terminal bisphosphonates are capable of activating the gamma delta cells, which is, you know, producing some side effects, we know. But on the other hand, a stimulation of those cells has a good effect because these cells are patrolling through the body and are helping to kill those malignant cells, unfortunately, we all have to deal with. So that would also have been my, for that additional explanation, first choice in this patient.
Yeah, and just to add to your final point, Frank, and I want Barbara to join in here, but the guidelines out of the oncology group now does recommend zoledronic acid over denosumab. There is data with particularly aromatase inhibitors showing that both drugs are efficacious in suppressing bone loss and reducing fractures, but the guidelines are now, for many of the reasons Frank suggested, not just for bone health, but for prevention of breast metastasis to the bone, are suggesting an aminobisphosphonate as a strategy over denosumab.
I may come from a slightly different angle here.
That's what I hit the.
Okay, thanks. Yeah, I might come from a different angle here because I think it's. Perfect. Thanks. When you think about who is at high risk of rebound fractures, this patient had already a vertebral fracture. We also know more younger patients seem to be at higher risk of having several vertebral fractures after stopping denosumab. And actually, some patients did or do need 3 infusions of IV zoledronate to completely switch off this rebound phenomenon. So I would be a bit cautious because she still does have increased bone turnover markers, CTX and P1 and P. And because of this risk, I think it would be a real shame if we say, okay, well, let's monitor, and then in 3 months she has sky-high CTX, P1 and P, and she may already have another vertebral fracture. So to be honest, I think I would, I think it's good to re-establish, to say, why is this discrepancy with lumbar spine and hip PMD? But I would think into, well, should we give another zoledronate infusion because she is in this risk group, which is at higher risk. Additionally, also, I think, we then likely have some time afterwards to see how it goes, but I still would monitor her BMD, and eventually, I mean, she is very young, she may be a candidate for anabolic treatment, but I would not jump into anabolic treatment now, because we also know if patients had prolonged anti-resorptive treatment before, then quite often the anabolic treatment is blunted. So, therefore, I would actually consider probably number 1 to go with minority.
Okay.
Would make any difference if you don't have considered anabolic therapy, but there's a 5th option, which is considered romosozumab or considered teriparatide. Namely, would make any difference between romo and teriparatide or PTH analogs here? Given the cancer, given the anti-resorptive activity?
It will come back in the next part. May I interrupt you? I'm sorry, just that we...
Go ahead.
Yes, so I'm happy, Barbara, that you said that, because that's what we did. We gave a 3rd zoledronate infusion, and she had strong side effects. That's something we observe quite often in the rebound. And however, it worked. So 6 months later, the bone turnover markers were within the middle normal range. And her bone density, you can see it here. It remained stable at the lumbar spine, but I think, as you can see here, the lumbar spine is falsified. And I think that's also the explanation for the discrepancy. She has osteoarthritis here, probably. However, at the total hip, she showed a quite big decrease, about 9% loss of bone density, and she's now again in the osteoporotic range, and you can see here the evolution shows she's basically back to baseline. So despite 3 zoledronate infusions, she had a huge rebound with a rebound-associated bone loss. However, Fortunately, she did not sustain a new vertebral fracture, which is, of course, the most important thing. She's otherwise healthy. She's meanwhile 61. And then we continue to control the bone turnover marks now every 6 months. And you can see that they remained in the middle to middle normal range. And now I just saw her last October. And this is the evolution of her bone density. You can see here at the lumbar spine the increase during the denosumab, then the loss of the zoledronic acid, and now she's stable. She shows a slight increase. However, she did not receive another zoledronic acid infusion. Now, I can't go back, however, I will tell you. At the total hip, she remained stable, which is a good thing. However, she came to me and she said that she had a distal radius fracture. She was walking with her dog, and her dog pulled her, she lost balance, and she fell. And now she has a radius fracture. And with 2 major osteoporotic fractures in Switzerland, you qualify for a reimbursement for an anabolic agent. And now I ask you, what would you do now? Would you continue with an anti-resorptive because it worked so far, the BMD remained stable? Or would you put her on denosumab again? Or now, this is now the point with the anabolic agents, would you give her romosozumab? Or would you give a PTH analogon? But keep in mind, she has a history of an early breast cancer. And now you can vote.
Most of them are going to Romo. So, well, we now start with Barbara and do the other way around.
Yeah. Okay. Can I just, briefly ask you again, what was the DEXA scores for hip and spine, the last one?
Minus 2.9 at the total hip, and the spine was minus 1.8, but I think it was falsified.
Okay, I understand. So, yes, I would agree with the history of a vertebral fracture, a recent non-vertebral radius fracture, and a hip bone mineral density well in osteoporotic range. I think romosozumab would be also my go-to choice. I assume she didn't have radiotherapy for the breast cancer, which would exclude teriparatide anyway. Otherwise, I think we are fairly comfortable with giving teriparatide in this case. But I think romosozumab would be probably the most effective in increasing hip bone mineral density, and she has been osteoporotic for a while now. So I think this is the best chance how we could hopefully increase the hip BMD.
We know the Wnt signaling is quite relevant in early breast cancer. You do not have any concerns that that could stimulate the cancer cells?
I think so far we don't have any evidence that romosozumab would increase the risk of cancer or recurrence of cancer. Actually, I know that I think in myeloma they even have done trials to see if it could be helpful as well in this case. So I would not have any concerns, but clearly it is a drug which has been we have started using it about 5 years ago in the UK, so I think long-term surveillance is still indicated.
So can I ask you the question, it's always a shared decision-making. So would your patient be happy to restart denosumab again? Have you asked her? Because, you know, the arguments are convincing in a sense, look, this is the huge increase you experienced with that drug. Then you stopped, okay, we did our best, that was not working so much, but now we could easily restart again in order to learn hopefully again that your bone mineral density is increasing, therefore your fracture risk is decreasing. So that would be my first discussion with the patient. Number two, for the reasons you gave, romosozumab is a great drug, but we have not long-standing experience with that, and your argument is valid. So I personally would be careful about that. And then the other thing is, if we think about sequential therapy, we seem to know, or well, it is known that first starting anabolic therapy followed by, let's say, anti-catabolic therapy is the better option, which we do not have here. So that is why I'm not saying it's not possible, but it would be in some sense suboptimal. So therefore, sorry for being a little bit long here, I would be discussing this with the patient. Maybe she has made up her mind again in favor of denosumab, and then I would be running denosumab again. Why not? Ken?
Yeah, I actually would give her Romo at this time, provided that, again, you reevaluate her for secondary causes. I'm still a little troubled by her lack of response to pretty aggressive therapy. And I'd check her PTH, I'd get a serum immunofixation electrophoresis. Is she hypermobile? Are there reasons to think she might have hereditary disorder of collagen that could be a form fruste of some other disorder? This just, it's something doesn't totally fit in terms of just sort of garden variety osteoporosis at such a young age with aggressive treatment with anti-resorptive. So I would do that, but I would always be rethinking the case to make sure we're not missing something.
Can I add a question to everybody, but just very, very quick, yes or no? Given that two of you will have given Romo and one denosumab, probably the two with Romo will follow up with denosumab. So basically the question is, would you be concerned of using denosumab for 20 years or not? Because that's a very pressing question in clinical practice. Can we use it forever, like we use, I don't know, methotrexate for 30 years or not?
Well, I think because we don't have any data for that, I would be cautious as well.
We don't have any data on...
From the 20 years of denosumab. I think you said initially that the patient was keen to actually come off denosumab, so I think having a treatment breaker, it would be in line with the patient's wish. The greatest chance would be with starting anabolic and then anti-resorptive. Also, I mean, this long-term oversuppression of bone turnover, what could that? I mean, there is certainly increased risk of atypical femoral fracture at one point. So I think, I wouldn't really, or would be careful with starting younger people denosumab and say, well, we can give this forever. I think there should be an exit strategy.
So I think the FREEDOM trial was ending after 10 years,
yep.
Right? Which doesn't mean there are patients being longer treated, so I've not seen any really big stop signal here, just to say you have to stop. And number two, you have treated your patient for 5 years before. So in other words, there are 5 years left, even back up by the FREEDOM trial. So we would have data on that, not for 20 years, but after 5 years, you could do another decision together with the patient, again, to start that.
I think I could do that, and probably I could convince her, but then after another 5 years, she would be, I think, 73. And then again, the question is, do I continue that lifelong, or do I switch her again to Sol? And we know it didn't work that well the first time. So what I did, I gave her abaloparatide, actually. I was more confident with that. But I don't know, so far she's still healthy, but I don't have any follow-up decks. So we'll see. Okay, if you agree, I will continue with the second case.
Judith, maybe we have some questions from the audience?
Sure.
So feel free to ask your questions using the app or microphones. Well, so that's not the case. So.
Okay, thank you. I'm sorry.
Oh, so there is one question. Sorry.
Hello, can you hear me?
Yes.
I'm slightly uncomfortable that the bone markers are so high after giving 3 doses of zoledronate at 3 monthly intervals. So I agree, we need to look why these bone markers are high. And we also know that she's had breast cancer and she had a vertebral fracture. So there is some explanation to look into why the bone markers were not responding the way we would. Theoretically, you are right that often we can have bone markers not suppressed with zoledronate, but 3 infusions of IVs all 3 monthly, that does need looking into. And personally, I would give this patient denosumab again, simply because we have data for 10 years. And by then we would know abaloparatide, but what will you do after 1 year? We can give her Romo, but again, what would you do after 1 year? So in some ways, we are safer giving 5 years of denosumab and then revisit.
Okay.
Okay.
Do you have any idea if the patient was still on aromatase inhibitor?
No, but I think that was the reason why she had such a high bone turnover in the
Maybe
beginning.
that's
I mean, she was also
one of the explanations,
sent
yeah.
very early into menopause when she had her breast cancer. I think she was 45.
Okay.
So that might be a reason, because we screened for secondary causes and we
okay.
couldn't find one.
Please go
And
on.
she was not pre-treated with bisphosphonates,
Yes,
right?
exactly.
Just
First
one
line.
last question, sorry. So your patient came to you saying, I have read about the effect if you stop denosumab, and that is why I'm, having not good feelings about that. Do you really think that you could have convinced her to start romosozumab? So just saying, it's a wonderful drug, but the arguments with the tumor cells and nobody knows, and we have not that long-standing experience, would you be happy to accept that? So, I mean, from your doctor-patient shared decision-making, would you expect you could have convinced her, just as a theoretical question? I personally would doubt that from the patient's profiles you have described so far, just as an additional point for making decisions.
Yes, I agree. That's always a challenge. I think back then with denosumab, it was a huge story in Switzerland to rebound. It was on national TV and cases were presented.
I think that came from Switzerland.
Yes, and that's because we used denosumab like calcium and vitamin D in the beginning. Every physician could prescribe it first line, no problems. So that's probably one explanation why we have so many studies about the rebound. That changed, too, so I can reassure you. Now to the second case, it's a 66...
One more question,
yeah?
sorry.
Sorry
for interrupting
Very
you.
quick question.
Yes, we...
Now we can hear you. Can you switch on the microphone, please?
How early after denosumab discontinuation do you start measuring bone markers, or how often do you do it?
So I do it every 3 months. That's also in line with some guidelines from the ECTS, for example. But I agree with you. Meanwhile, I'm not sure if measuring the bone turnover markers is really that helpful, because my impression is that we can give 1, 2, 3, 4 sols. It doesn't change that much. I see patients which have a huge rebound bone loss, and others, they only have small bone loss. And there seems to be other predictors of that rebound response than zoledronic acid. And that's also found in clinical trials. So there is one trial from Bente Langdahl. All patients had a bone loss irrespective of the numbers of zoledronate infusions. But that's my personal opinion. I give 1 or 2, but not more nowadays.
Case number 2, please.
Okay, thank you.
You're knowing now.
So this is a 60-year-old woman with seronegative polyarthritis, most presumably chondrocalcinosis. And she was initially treated with methotrexate for 3 years. Later, she inhibitor, a JAK inhibitor, and it was very challenging to treat her. She also had secondary osteoarthritis and most likely fibromyalgia, and she always thought she has flares when she had pain. She also received oral and intra-articular prednisone several times, and her comorbidities included a monoclonal gammopathy of undetermined significance and obesity. And this is her bone density. In the beginning, she had osteopenia with a T-score of -1.1 at the lumbar spine and the normal bone density at the total hip. So that was reassuring, but she had another problem. She had repetitive lower extremity fractures. And you can see it here, several old fractures here with callus formation. Here one dislocated fracture, here one fracture at the base of the metatarsal 3. Also here she had old fractures, and she also had fractures of her tarsal bones and of the distal femur. And without any additional information, I ask you, what do you think caused these fractures? And you can choose several answers if you think it's more than one cause. And
Go, start.
It doesn't work.
Can you please start voting from the...
It's not responding.
Think about the answer.
Okay, I go back.
Otherwise, we can show the hands.
Yeah, I mean, we can skip the question.
Or, well, what do you think? Is intraarticular glucocorticoid therapy? Please raise your hand if you're going for the GOP. Not that many, not that many. Go back. How many of you thinks it's methotrexate?
I tried again.
Most of you thinks it's methotrexate. Huh? How many thinks it's just, I don't know, an hypophosphatasia or whatever genetic condition, very rare? There's a lot of fractures there. Only a few of them. No, now more. And who thinks it's the seronegative arthritis causing all of these fractures? Not many, but someone. What is the expert thought about that?
So, Barbara, maybe
Well,
this is... Oh, no, sorry, Professor Stack.
She deserves an ALK phos for sure, right? Everybody agree? Should we get an ALK phos and just be sure she doesn't have hypophosphatasia?
Do you think there is a patient that does not deserve an ALK phos? Everyone
Well,
deserves.
I mean, this is a better situation, right?
That's the best.
She's got multiple fractures and chondrocalcinosis. So that definitely needs to be tested. I think methotrexate osteopathy is a concern, and we know Dr. Grabers has an interest in that, so it may be a reasonable clue. But, you know, let's see what her testing here has shown.
So please, explain.
So I did not show it before, however, now you can see it, the calcium, PTH and phosphate, as well as the vitamin D were always normal. She had low to moderate bone turnover, but she also received bisphosphonates. And the alkaline phosphatase was 2 times decreased, and that's why we screened her for HPP, but it was normal, so it was not HPP. And I can show you what we did. We stopped methotrexate because I'm not sure if methotrexate osteopathy exists. There is a weak evidence. It's based on case series so far, and there is a high risk of confounding.
Please stop. We might have Barbara commenting these as she published on that.
Yes, my heartbeat just skipped.
No, please comment that. Do you think that methotrexate osteopathy exists?
Yeah, I mean, it's interesting because you're right. I mean, it has been for 50 years ago, the first cases presented, and it was case series until 2021, and then there were larger case series, and still up till now we only have case series, so that's true. However, so our cohort in Edinburgh, we have looked at patients retrospectively who had methotrexate-related fractures, and we looked at those who stopped methotrexate, and those who continued with methotrexate. And we found that those who continued with methotrexate, they had several further, mostly insufficiency fractures when they continued methotrexate, whereas the ones who stopped it, it seems to have there was minimal further fracture seen. So I do think this is one of the kind of evidence what we could give. Clearly, it is still not randomized controlled trials, or we still have a lot of questions in regards to pathophysiology, but I certainly think that in this case, stopping methotrexate, minimizing glucocorticoids is certainly the right thing to do. She has this multiple density, and they are quite the typical locations for the methotrexate osteopathy, what we see. So I do think that absolutely stopping methotrexate was the right thing.
Yeah, please. So I think there are really, can you hear me? No. It's on. It's on? Hello, yes. Yeah. So there are really a few things to be discussed here. Number one, I would not call this either or, I would be calling this and. And I mean that there are, from my point of view, clearly, signs of methotrexate osteopathy, but also of glucocorticoid-induced osteopathy. And keep in mind, the BMI is 30-something, so there's quite some heavy weight on these bones that in the end were broken. Number two, I'm not sure what the inflammatory activity of this patient was. I seem have to understood it was not that big, and she was complaining about pain that could be easily related to secondary fibromyalgia. Nevertheless, she was treated with glucocorticoids. So what I'm always saying is, if you have low dosages of glucocorticoids that help to antagonize inflammation, then the negative and positive effects may be leveling out. But if you not have any inflammation, you are just being left with the bad effects of the glucocorticoids, killing the osteoblasts, bringing osteocytes into apoptosis, inducing osteoclasts. So I'm convinced there is a component driven by glucocorticoid-induced osteoporosis, right? And the conclusion you made is perfectly fine. I do not see an absolute need for methotrexate. I really need some good arguments to take this out. So it's pretty clear, remove methotrexate. That's the only decision. And then more tricky is try to avoid, and you are writing trying. You need to do everything in order to get the glucocorticoids out of this patient. And I think the wrong thing to do is to go down from 5 to 4. You just say, come on, you have 5. From tomorrow onwards, you just take 4. That never ever works because it's a reduction by 20%. I would be doing in this patient, saying every day 5, but only Wednesdays and Sundays 4. Do that for 6 weeks or 8 weeks. It doesn't matter. It's so long, it doesn't matter. And tell me if you have a problem on Thursday and on Monday. And if not, then I'm going to 5, 4, 5, 4 for another 6 to 8 weeks. And then I would be trying to achieve 4. And then on and on and on. That is the only way it works from my experience, I should say. And the biggest mistake is just to say from 5 to 4. It's just a milligram, forget it. It's huge. It's huge for a long-standing therapy. So that is just, I would be underlining with the wording, trying to avoid glucocorticoids. I would be saying, do a very, very slow but consistent tapering, whereby the English word I was learning from Ken, tapering means in their language, go down to 0. In our language, it would meaning go from 5 to 4, maybe stay at 4, go to 3, stay. No, tapering means go out.
Okay, I think we are running out.
Okay,
go on.
I will continue.
Yeah, please.
Okay, so that's what we did, and now you see here her bone density, it increased because now she was on denosumab, and she still received a low-dose glucocorticoid therapy. It was impossible to stop. We come back to that later. And she still was in pain, and the CRP was normal, and we had to convince her that this is not an inflammation in her body. And what we did was a bone scintigraphy, which showed a tracer uptake in the typical joints, active osteoarthritic changes. However, the radiologist also mentioned a focal tracer uptake in her distal femur. And yes, she had thigh pain under denosumab. And here you see the SPECT CT. And the radiologist, it's in German, but I can tell you, he thought this is a benign bone tumor. However, I suspected an atypical femoral fracture, and so I wondered what could I do next. And you can, it's
Hopefully start
not
voting.
working again.
Not working.
Okay, we just discussed it like this. So I was wondering, should I stop now denosumab to prevent the complete atypical fracture? Should I add teriparatide to denosumab? Should I switch to romosozumab? Or should I consider a prophylactic intramedullary nailing?
So we can have the audience asking. Seems to work.
Okay.
Can we have the results? So please vote, even if it's not showing. It doesn't work anymore.
Because the internet connection here is so slow.
The internet connection.
Oh, we are so sorry about this. There's nothing. It just freezes because it's so much data at the same time.
Okay. Yeah, EULAR is well attended this year. I know. Don't worry. How many of you use combination therapy in osteoporosis? Please raise your hand. Some of you, which is good. So someone would add teriparatide. Okay, good. Well, maybe we can go on with the experts. What does Ken, please give your opinion in that? A typical femoral fracture here.
Yes, so we saw the next picture, so we've cheated. So it looks like number 4 was probably something we should have done in hindsight, because sometimes we're a little reticent to put in a rod if there's not a through-and-through fracture, and many of our surgical colleagues are a little more aggressive and want to do it sooner, and you know, as internists and rheumatologists, we tend to withhold intervention, but obviously that was the right thing to do. You know, with an atypical fracture, normally we do think about an osteoanabolic. Teriparatide would be the thing that would be most in sync with my top choice. The problem is after denosumab, it may take a year before you can stimulate the bone well enough to get any benefit from it, so you lose a period of time. I think Romo is appealing, although as some may know, in some of the studies, in the FRAME study, there were a couple cases of atypical fractures in ONJ. Now, that's pretty small given the size of the study, but there is some anti-resorptive benefit with romosozumab. It's not a pure anabolic agent. So I think I probably would have taken a chance with teriparatide in this patient, in addition to, you know, putting in the rod, now that I know what happened.
Thank you.
I have nothing to add. Exactly my opinion. Sorry for this.
I mean, because the patient with those fractures, insufficiency fractures, she had low bone turnover to start with. Is that right? So it is probably a bit of a iatrogenic issue as well here, but also I think teriparatide, I would go for that. Just to refer back to the methotrexate osteopathy, there is not great data about what we should do in terms of osteoporotic treatment, but there is the Hamburg group, and they had some evidence that with anabolic treatment, with teriparatide, there is earlier mobilization and better healing with teriparatide as well, because possibly there is some low bone turnover, which is hindering the whole fracture healing and this persistent insufficiency fractures. So, yeah, teriparatide.
So Barbara, switching or adding an anabolic?
I mean, she only had denosumab. For how long did she have denosumab now?
It was 2 or 3 years, but she had bisphosphonates for many years before.
Yeah. So we are in a very tricky situation, so I would probably add teriparatide in order to avoid the rebound.
I just want to throw out one other thing, and I'm very curious to hear what Bjorn's going to say here, because he deals with a lot of rare metabolic bone diseases, but my colleagues who focus on that in particular tell me that the genetic testing is not 100% sensitive. And is it possible that she has a form Frust of a rare metabolic bone disease? She's had consistently low ALK phos, although just a few were below the lower limit of normal. I mean, I would want to look at a B6 and some of the other things that you may see that can be indicative of that. And so maybe we're dealing with something a little bit different here.
Good.
Veering from Germany, I actually wanted to go completely a different route and ask the question what your guys' experience is on teriparatide and pain reduction. So I'm sometimes very pragmatic, and I think in this case you could say you can kill a lot of birds with one stone by adding teriparatide, because if it's methotrexate or insufficiencies or steroid-induced osteoporosis, we've got good data from teriparatide. But I'm curious on your personal experience of, because I have some spine surgeons who want to try to convince me to start teriparatide in hospital quickly because they swear it does add pain reduction. So I was wondering what your experience is in that.
Well, I have seen those patients who were reporting pain, but pain is always very subjective. And if you tell them, look, this is a mechanism, there's some ancient explanation from our development as a human being, it could well be. So you are supporting this, and I'm not sure how much placebo effect on top of maybe really existing effect comes on top. Yeah, my answer is yeah, I've seen that, I've heard that, but the numbers are small, and I'm not sure whether there is a real explanation for that or whether it's the the white coat effect.
I mean, just looking at insufficiency fractures, if obviously fracture healing is in place, and if the teriparatide helps the fracture healing, then there is pain improvement. By the way, that was also reported in the and in regards to atypical femoral fracture or otherwise pain reduction, I don't think we are having any solid data behind that.
Okay, I will continue. So we added teriparatide. Later she had denosumab only and was then switched to solidronate. Her seronegative polyarthritis was calm, it was stable, but she stayed on 2.5 milligram prednisone daily. It was impossible to reduce that. We tried it several times. At least she had no further fractures, but she suffered from pseudoarthrosis and osteoarthritis. And here you see her bone density. She has now plus 2.1 at the lumbar spine, and also in the normal range at the total hip. And my question now, and I think we can discuss it, how should we manage her low-dose glucocorticoid treatment in the long run? Should we avoid anti-resorptive? I mean, she had an atypical femoral fracture. Should we use it, but very infrequently? Should we consider another anabolic cycle, perhaps with romosozumab, or should we only consider that in case of a new major osteoporotic fracture? What do you think? It's working.
Yeah. So there is a lot of controversy here. Please, make it controversial.
Well, so I'm not sure she needed any resorptives to begin with because she didn't have typical fragility fractures. And so I'm not super enthusiastic to give him back to her now that she's had an atypical femoral fracture. And I would go with the audience response.
Which one?
Which one?
The winning one.
The winning one by very small. Okay.
Can I first ask you, what was your argument against romosozumab? Because you were deciding to do a dual therapy by adding teriparatide to denosumab. So why haven't you chosen the romosozumab, as Ken was explaining, also having a dual mechanism of action?
So the simple answer is back then Romo was not available in Switzerland. But I wouldn't give her Romo because I think with her low bone turnover, teriparatide, which stimulates bone remodeling, is preferable, first one. And second one, I'm hesitant to switch to Romo after long-term denosumab because I don't know if this is really helpful. After 1 or 2 doses, I don't think it's a problem. But after long-term denosumab, I don't switch directly to romosozumab.
But I agree with Ken's argument that was after many years of bisphosphonates plus, I don't know, 2-3 years of denosumab, you need to wait quite a while before teriparatide can really produce objective effects, to at least regarding what we seem to know. So that's a valid argument. But in the end, it was increasing, so okay. But still, 2.5 milligrams is not sky high, and the risk is not sky high. But I mean, 2.5 milligrams in this case are not indicated. So again, you need to fight. And if it takes a year to bring her down from 2.5 to 2, again, that is what I would be saying. On the other hand, yeah, I would be also voting for number 4. That would be in this situation then my approach.
I agree.
You agree? What about a very short-term romosozumab course? It's a anabolic mostly in the first 3 months. So why don't we give just 3 months of Romo?
Well,
and I
think that's a very exciting approach. The paper out not too long ago by Leader and colleagues showing that 3 months followed by denosumab was non-inferior to 12 months. Now, it was just barely non-inferior. In fact, it was worse, but it didn't suppress the non-inferiority margin. And in fact, there were slightly more fractures in the people that had 3 months versus 12 months. But I think for certain patients, that may be a very viable option to stimulate the bone a little bit before you add another anti-resorptive. I wouldn't do it for her, but I'm thinking a lot about that approach now.
Let me ask you one question. So for me, to be honest, this case is not completely solved. Have you considered bone biopsy or another genetic testing? Because considering atypical femoral fracture, metatarsal fractures, low ALP, seronegative RA, I don't know.
No, we didn't, but I agree with you. Something is not, I mean, she can have an underlying genetic condition apart from that what we tested. I agree with that. But now she has no more fractures, so I'm happy. But yeah, we should think about it later when she has another fracture. Agreed.
Microphone in the back.
Thank you. Can you think it's be useful to get an access of cortical porosity with HER picusity in this case to approach the bedside goal to the decision in therapeutic?
Yes or no?
I don't think, well, I'm not sure whether it would change my management at this stage with normal bone turnover, no recent fracture. I think even if her cortical porosity would be lower than normal, I think I would hold off at the moment with treatment.
So you could ask me maybe in 1 year, because we are running this in our cohort now, comparing all of these approaches, but we don't have yet the answers, focusing on glucocorticoid-induced osteoporosis. So given that the 2.5 are contributing here, but still we don't have the answer, but maybe next year.
Okay. Anything to add? No.
Okay, then we come to the next case. It's a 65-year-old woman. She has a normal weight, no history of fractures, and she was diagnosed with rheumatoid arthritis in 2023. her ACPAS and Rheuma factor were highly elevated. She already had erosions at the hand and at the feet, and she was treated initially with low-dose prednisone, 5 milligrams, but only for 2 months. Later, she had methotrexate and a TNF inhibitor, and now she's in stable remission with an anti-IL-6 treatment. You can see her erosions here at the MTP joints, and also at the MCPs, she had erosions which were at least visible in the ultrasound. And we also tested the bone density. We always do that. She has several risk factors. She's postmenopausal, she's a woman, and she has a history of rheumatoid arthritis with high ACPAS. And indeed, she had a very low bone density with a T-score of minus 3.7 at the lumbar spine and minus 3.1 at the femoral neck. Her lab tests were normal. She had a mild lymphopenia under tocilizumab. And however, there was one thing which was highly elevated, and this was the P1NP. It was over 200. So there was an active bone remodeling, bone resorption. And when we thought about treatment, we calculated the FRAX, which was 33% for a major osteoporotic fracture, and her FRAX plus was even higher. And with that value, she is in Switzerland borderline between high and very high risk and would actually qualify for a first-line anabolic treatment even without prior fractures. However, she has a very high bone resorption, and I wonder, should I just start with an anti-resorptive to lower this bone resorption, or should I give an anabolic treatment? And you can here see the treatments.
No one will use any more denosumab. We're scared of people. So, what about Ken? What you have done here? She doesn't have fracture, but very high risk.
So, I'm in between 4 and 2. I was interested that 2 did so poorly. I'm, like you, a little concerned about giving her an osteoanabolic with such high turnover, and I'm tempted to use an anti-resorptive. If I'm going to pick one, I'm going to pick the strongest one I can get my hands on, which is denosumab, which, by the way, has data in RA, never got an indication for RA, but has data in RA showing that it may have benefits on bone erosions. Mm-hmm. So that has some appeal to me. But she's got pretty darn low bone density, and I think Romo would be a reasonable choice. I'm not used to giving it to people with turnover that high, but I think she'd do fine with it. So I think I might, again, go with the audience's top choice and use Romo, but denosumab would be close behind.
Yeah, I also agree with the audience. In this case, rheumatology, because of the dual mechanism, would be targeting both things, would be presumably increase pretty rapidly bone mineral density, thereby decreasing the fracture risk, would be addressing the lab parameter, the obviously elevated bone turnover. I'm also surprised to see why, I mean, number 2 is really low, and I cannot see the argument against denosumab. It would be also a good idea because it's pretty potent, as we have seen in the other cases and from our own experience. And the parameter you mentioned give a good handle to target, to shoot on that, what happens there, despite the fact that you have shown the star between red and very red, because you would be addressing the problem if you shoot down the osteoclast overactivity. And number 3, zoledronate is also a good choice in this patient. So my ranking would be place 1, romosozumab, and close behind either or. I mean either denosumab or zoledronate.
Yeah, I think romosozumab would be an interesting option, particularly if you think about goal-directed treatment. So she has very low lumbar spine. We would like to get, I think, the low BMD, if possible, into osteopenic range. And I think we would only get there with anabolic treatment first and then anti-resorptive. Yeah, however, so I'm working in Scotland. We could not prescribe romosozumab because she didn't have any recent fracture. So, yeah, the second option would be teriparatide. We could prescribe that, but I would also be slightly hesitant about the high P1NP. Although I don't think we have that great data that bone turnover markers really predict the treatment response. So I think it will be a discussion with the patient. In my clinical practice, I could either use teriparatide or denosumab, but I wouldn't completely exclude the teriparatide in this case. Yeah, because as I said, surprisingly, and just to say that with rheumatoid arthritis, we know generally patients have elevated bone turnover, but when we look at how they respond to teriparatide, generally very well as well. So I think it might be an option there.
Okay, I show you what I did. It's a bit unconventional. Of course, we gave vitamin D. And then we gave one denosumab injection. And the reason for that is we did not get the reimbursement first. And so we had to discuss with the health insurance. However, we got then the reimbursement, and 6 months after this last denosumab injection, we started with romosozumab for 1 year. And fortunately, it worked very well. Her bone density increased by 21% at the lumbar spine and 23% at the total hip. So now she's even in the osteopenic range, so your goal-directed strategy, it worked in this case. Now she's on zoledronic acid. And now we come to the last case. It's a 60-year-old woman with a psoriatic arthritis. She's in remission with an anti-IL-70 strategy. She has normal weight, no fractures, but she was diagnosed with osteoporosis 2 years before with a T-score of the femoral neck minus 3.2. And then we gave her 2 zoledronate infusions, and this worked. Her bone density increased by 10% at the lumbar spine and also 10% at the total hip, which is a quite good response under zoledronic acid. And she had no new clinical fractures, but when I looked at the vertebral fracture assessment, I suspected here a new vertebral fracture. And I was quite irritated because she had this nice increase in bone density, but still a new vertebral fractures. This is strange. And so I did an MRI, and the MRI showed no edema. So this is not a new fracture. The radiologist said it's an old fracture, or at least not within the last 12 months. And however, here on this, no, I can show it. Well, I was unsure, what should I do now? Should I consider a drug holiday? I mean, she had a nice increase of her bone density. The fracture is probably old. Should I continue zoledronic acid? Should I switch her to denosumab? Or should I consider an anabolic therapy? I mean, she's young, she has a vertebral fracture, and she would probably benefit from that.
I think that truly the question here is, she's on target, she has been done good or not? And what is the treatment target in osteoporosis? Because that is really the hot boiling question here, is whether, you know, she got an improvement in BND, get the CTX is going very good, everything is fine. She was happy, but then she found this maybe vertebral fracture. So,
did she ever have back pain, a bad episode of back pain lasting for 6 weeks or more? I share your concern that this may be a prevalent fracture, and that as a result of that, we don't need to be more concerned than we already were. We know that in men, 15% of men at the age of 50 will have prevalent fractures. And so that can be very confusing when we look at imaging, and that's why the MRI was appropriate, and trying to figure out the age of the fracture is key. So again, I agree with the winner here. I would continue what you're doing. I would probably treat her for a period of time with zoledronic acid. I'd take a 1 to 2 year holiday. I'd follow her turnover, and then continue that course of therapy based on how well she's done.
Yeah, I think BMD response is still one of the best markers of treatment response, assessing treatment response. And for zoledronate, she had very good response. I think 10% both sides. So I think that's a sign, absolutely, that it's working. And I think we could also consider a holiday and monitor the DEXA scan in 2 to 3 years and see how she is doing then, and maybe reconsider at that point IV zoledronate, or we can continue with bisphosphonates. It's also a bit of a discussion with the patient. But yeah, I mean, clearly, if she would have a new vertebral fracture, that would give us really a headache there, because on the other hand, she responded well from a BMD point of view. And we know that in clinical trials, even if patients have responded well, it's not some patients still will sustain fractures. But clearly, vertebral fracture, that would be disappointing to see. So.
I think we would be offering both option 1 and option 2. I would just explaining, look, we have achieved a lot. Your bone mineral density increased, which is great. On the other hand, there is a little concern regarding your X-ray. It's obviously no pain, no fresh fracture, so it's not an acute problem, but there is something. So there are 2 ways. The one way would be we now start drug holidays, and after 2 years, that is what we would do. We look at you again, plus, of course, come back earlier if there's a problem with something. The other way would be to continue for another 2 years the bisphosphonate therapy in order then to start drug holidays. I think both ways would be feasible. Both ways are, have pro and cons, klar. And I would also include the patient's decision, whether she wants to be rather more on the safe side in terms of therapeutic efficacy, in brackets, but there can always be side effects, that's a risk. And on the other hand, you stop the treatment, you stop the drug risk, but on the other hand, it could be, deteriorating what we have achieved so far. So it's there's no black and white decision. It's also to bring in the patient's opinion at the end.
Yeah, so I discussed it with her. I mean, with her good bone response, a drug holiday would be a possibility, because I think continuing zoledronic acid wouldn't have improved her bone density that much. It would be simply a consolidation and stabilization of BMD. However, I thought, obviously, I underestimated her fracture risk in the beginning, because she had a vertebral fracture, which I missed on the first VFA.
We have a question here from the audience. What about the bone resorption marker used here? So basically, we all agree that a drug holiday is good for this patient. Maybe she got a fracture right after the first zoledronic acid, then consolidate, and she got a real good improvement, so we are on target there. But do you use CTX? And what threshold for guiding drug holidays? Do you have a threshold in your clinical practice?
We don't routinely use bone turnover markers, but I think in terms of, particularly if you have prolonged treatment and prolonged anti-resorptive treatment, then it is helpful to see because as I think Professor Sarg mentioned initially, that we have data from New Zealand that IV celedronate can really suppress bone turnover for a very long time, so it makes sense to try to, after prolonged antiresorptives, to check P1 and P CTX.
What one is the best one, CTX or P1NP?
Well, we just manage, if possible, to get P1NP because it's the easier marker to treat. And I think from the Sheffield group, they use more P1NP. But I would probably defer to other experts from bone turnover.
I think whatever you have easy access to. We happen to use a lot of urinary N-telopeptide assays, and even though there's more diurnal variability, it seems to be pretty helpful. And I would check one before starting a holiday, and then I'd bring the person back every year and I check it, and if it remains suppressed, as it often does, then I may extend another year and bring them back a year later. After zoledronic acid, it may be 2-3 years before I'd redose.
What is suppressed?
Suppressed is below, so the range we use, premenopausal reference range is around 30. If it's below 30, then I'd continue on the holiday.
Go on, please.
Well, that was my last case.
Okay, so get back to that question, because that is very, very important question. We have just a few minutes left.
And also a few questions in the chat.
And there are a few questions in the chat. Well, not related to this, I think. You can look at that. But I think this is one of the most important question and pressing question in osteoporosis world, and we don't have really an answer for that. How do we define treatment failure? Which one is the best, in your opinion? Please, expert, tell us.
Well, I think, so the answer is all of them, and we need to integrate them, and we need a way to do that. We need a response criteria for when people are responding or not responding, because then there's other covariables in here. So, for example, if somebody is getting the right therapy and otherwise doing well, but their steroid dose goes up to 30 milligrams a day from 5 milligrams, and they're losing BMD, you can't necessarily blame it on the treatment. So there's other things that we have to always integrate in all the clinical information in defining whether someone is truly failing the treatment we've started or whether there's an alternate explanation. So I would integrate these things along with clinical information, and hopefully we're going to do that. Hopefully we're going to develop a decision rule, a response criteria that could weigh the different things that we might want to consider, and that may be done using a formalized group process and conjoint analysis similar to the way other criteria sets have been developed.
Yeah, I mean, the hardest criterion would be the new fracture. If a new fracture occurs, then it's, by definition, a treatment failure.
But is it, I mean, a fracture is, I mean, you fall, you have a fracture, you wouldn't have that fracture if you didn't fall. It's a bit arbitrary.
Yeah, but the fracture is a fracture because it's reducing living quality. The patient, I mean, the patient is not very much interested in a decrease or increase in BMD because he or she is just saying, okay, doctor, but I don't feel this nut. And the same is for the bone turnover. The fracture is different. That is why in this ranking, of course, it's a complex approach, but in this ranking, fractures is the highest because we should not forget BMD is a surrogate, and bone turnover markers are surrogates. I mean, bone mineral density is not equal to bone quality. That is what we all know, especially if it comes to glucocorticoid treatment. So the BMD could be the same as in the postmenopausal. Nevertheless, the bone quality is not that good. So we need to be aware, and we need to stay aware that these parameters are helpful in clinical practice, but nevertheless, they are just surrogates. And I'm still convinced all what counts is the prevention of fractures, because we know that fractures are really putting a lot of problems to our patients and their relatives in the end.
A very short closing comment.
Yeah, just in terms of fracture, I also think it's a combination. However, fractures, I would differentiate if it's vertebral fractures or is it a wrist fracture, because we know as well the treatments, they do reduce the risk of vertebral fractures massive by 70%, whereas wrist fracture 20 to 30%. So I think that needs to be taken into account, what type of fractures as well.
Good. I think you can close.
No, please go.
So, well, thank you. Thank you, everyone, for coming today. We got a really wonderful experts discussing really interesting cases. Thank you, Judith, for that, and hope you enjoyed this.